I'm Dr. Deva Boone from the Southwest Parathyroid Center, and we're back to the parathyroid education course on Facebook. I am going to talk tonight about genetic causes of high calcium. So a lot of patients with parathyroid disease wonder if this runs in families. A lot of conditions do. For the most part with parathyroid disease, it usually does not. We don't see it running in families, but there are specific situations where it very clearly does run in families. So this can be a genetic condition. Parathyroid disease or high calcium can be a genetic condition. And I'll talk about basically why we care and who might need to be tested. Basically, with parathyroid disease, like I said, most people, they get it. It's spontaneous. They have no family history. Nobody in their family has ever had high calcium. They notice that their calcium is high. They get tested. They're diagnosed with parathyroid disease and they get surgery. They want to know if they need to get their children tested or other family members tested. For the most part, you don't need genetic testing. If you have had parathyroid disease, I do recommend telling your family members. So tell your children you had this done just so that they know it for their own history, their own family history, because there is a chance that you could have a familial condition. But I don't recommend just routine genetic testing for everybody. I do get genetic testing fairly often though, because there are people who do have these genetic conditions. Okay, so let me switch over. These slides are extremely basic because I don't want to get into, too many details of genetics that we don't necessarily need. But there's a couple things that I want to cover and just so you have a visual thing to look at. So again, most cases are not familial. They're going to be spontaneous, sporadic, primary hyperparathyroidism, meaning you get it, nobody else in your family has it. You'll probably get it at the average age, so older adults, it's and most of the time, if I don't have any other suspicion, I'm not going to order genetic testing or even really think too much about a familial condition for most people. Okay, but there are cases in which I start to think about a genetic cause of high calcium, and I want to just back up a sec and say that there are two main categories here. So there is FHH and then there's familial hyperparathyroidism. And these are two completely different conditions, but both of them present with high calcium. FHH is familial hypocalciuric hypercalcemia. And what that means is that you have a low urine calcium and a high blood calcium that is lifelong. And it's because of your genes. FHH is one part of it. This is different from primary hyperparathyroidism, different from what I normally talk about, because it doesn't need to be treated necessarily. Most people with FHH are going to have high calcium levels for their entire life, and it's not going to change. They may have normal or slightly elevated PTH levels, again, that usually don't change too much, and you will not benefit from surgery in most cases. So for most cases of FHH, we kind of want to diagnose it before surgery because after surgery, a lot of times people are not going to be helped by surgery. So if you diagnose it after, that means that, you did an operation where it was necessary to figure it out. But it's nice if you can diagnose it ahead of time. So again, you can't always diagnose FHH ahead of time. Sometimes you need surgery actually to figure it out. But sometimes you can figure it out before you go to surgery, and that's always ideal, is to try to figure it out beforehand. Okay, so what is familial hyperparathyroidism? Well, it's different. That's when you actually get parathyroid disease, meaning you get a parathyroid tumor or parathyroid hyperplasia, an overgrowth of the parathyroid glands, and it's something that runs in your family. You're not born with this. You're not born with hyperparathyroidism. You're born with the genes that predispose you to it, but you're not born with the condition. So not everybody, born into a family where this gene is prevalent will even have the gene. And even if they have the gene, they may not get hyperparathyroidism. But at some point in your life, you may get primary hyperparathyroidism. So in your early adulthood or teens, your calcium levels are normal. And then at some point you develop primary hyperparathyroidism. That could be familial hyperparathyroidism. Again, usually it's not, but sometimes it can be. So remember that these two are two completely separate conditions. A lot of times the gene panels that we order actually include the genes for both of these, but these are caused by completely different genes. Not the same genes cause FHH and familial hyperparathyroidism. In general, there are some rare exceptions, but in general, these are different genes and different presentations. So with FHH, I've mentioned it before, and I sprinkle it throughout because it's something that you always kind of have to have in the back of your mind thinking about. But FHH really it's a condition where you have high calcium levels your whole life, and you're probably not going to benefit from surgery unless your calcium levels have really changed over the last couple of years. So if they've suddenly gotten much higher calcium or much higher PTH levels, sometimes those patients actually do benefit from surgery. So there are people with FHH who should get parathyroid surgery, but it's not the most common scenario. People with familial hyperparathyroidism, on the other hand, are treated with surgery. It's treated just like any other primary hyperparathyroidism where you get an operation. It's really important in these familial cases actually to look at all 4 glands because when you have a familial hyperparathyroidism, typically you get multiple parathyroid glands involved. Some of the genes can cause just parathyroid tumors, like a single parathyroid adenoma, but for most of the cases with familial disease, we'll often see hyperplasia, which is when all 4 parathyroid glands go bad. And even if somebody presents with one adenoma, if they've got one of these genes involved, there is a much higher likelihood that at some point down the road, sometime later in life, another parathyroid is going to go bad and they're going to need surgery. So important to look at all 4 because of that high prevalence of multi-gland disease. Okay, so why even test genes and who needs it? But first, why test the genes? So there's multiple reasons to understand your genetics, right? A lot of times people are thinking about cancer with genetics, and if you can screen for some of the genes involved in cancers, then you can figure out what cancer you might be able to get down the road, and you can either prevent it or you can screen for it and look for it. For parathyroid disease, these parathyroid tumors in general are benign. They're not parathyroid cancers. Now, there is one gene associated more often with parathyroid cancer, but for the most part, in nearly all cases, these are going to be benign parathyroid tumors. So we don't necessarily kind of need to figure it out so we can catch it before it happens. The main reason to test genes is, one, to understand your family and your risks for your children. So if you do know that you have a gene associated with primary hyperparathyroidism, it makes sense to let your family know so that they can also look for their calcium levels. But again, remember I told you, if you've had parathyroid surgery, I recommend telling your kids anyway so that they can, that they can watch out for high calcium in their life. And if they do get high calcium, they'll know, okay, I know my mom had this and I'm at a higher risk for it. But if there is a strong family history and it can be helpful to know that there's a gene involved. The other reason is a lot of the genes that cause primary hyperparathyroidism will predispose you to other tumors, not just parathyroid tumors. So the main thing here is MEN syndrome, which is multiple endocrine neoplasia, which basically just means multiple, meaning more than one, endocrine meaning of the endocrine system, neoplasia meaning tumors. So it's basically if you have multiple endocrine tumors, so tumors of the endocrine glands, then you may have MEN. And there's different syndromes here. The one that is most often associated with primary hyperparathyroidism is called MEN1. And if you have MEN1, if you have that gene that causes it, then you really want to know about it because it can cause other tumors like pituitary tumors, pancreatic tumors, things that you want to screen for and want to figure out early on and see if you have that. Same for the other MEN syndromes. You want to know because there's other things that you need to look for, and certainly if you've got MEN, you want your kids to know. Okay, so who needs it? Basically, if I have a suspicion that you have familial disease, I'm going to recommend testing. Testing for genes, it used to be really expensive, really hard to get. It used to be a big production. And so for a long time, we didn't really test these genes. You would diagnose things kind of, more based on the clinical presentation. So you would diagnose MEN1, for example, if your patient had a pituitary tumor and had parathyroid hyperplasia, and maybe had a family history of pancreatic tumors, then you can kind of say, okay, this looks like MEN1. But now we know all these genes. It's very easy to get. I can order genetic testing online for people. They mail a kit, you do a mouth swab, and you mail the kit back. And usually we get a result in a couple of weeks. So it's very straightforward now. And so a lot more people are getting the testing. Again, I don't think you need it if you have no other reason, no other indication of having familial parathyroid disease. So most people, I don't really recommend it. There are some scenarios in which I recommend it. Okay, so I'm going to go over those. So one is if I have any suspicion of FHH. So getting back to FHH again, if there's any suspicion for FHH, I will recommend genetic testing. Now, when do I suspect FHH? Well, as I said, with FHH, you have high calcium levels your entire life. So if a patient tells me that their calcium was high 30 years ago or for the last 30 years, then I'm a little suspicious. I'm thinking, okay, you've had high calcium for 30 years. Let's get more information. I'm going to tell you to go and ask your family members specifically, do you have high calcium? Did mom ever have high calcium? Anybody ever mention high calcium? Because I want to know, maybe your family members actually have known their whole life they had high calcium and nobody ever mentioned it because nobody brought it up. So I want you to do that. I will get a urine calcium, a 24-hour urine calcium. With FHH, typically we're going to see very low urine calciums. So if I see that kind of history, long history of high calcium, maybe family members who've also had high calcium, then I see your urine calcium is low, I'm going to recommend testing for the FHH genes. If those are positive, then most of the time I'm not going to recommend surgery. Sometimes I will. Those are very specific cases. But, okay, there's also times when I'm thinking about familial hyperparathyroidism. In that case, this is when it's important to ask about, one, the family history, but other endocrine tumors. So I'm thinking about it, if I look at your history and I see that you had a pituitary adenoma that was taken out years ago, or if in your family, there have been, pancreatic endocrine tumors. Now, pancreatic cancer is usually adenocarcinoma. It's not an endocrine tumor. The pancreas has both exocrine and endocrine cells in it. Most of the time, our cancer is with those exocrine. Those are the ones that produce the digestive enzymes. Sorry, I haven't had to talk about this in a while. But the endocrine parts, there are also endocrine cells, which are the more classic, hormonal cells. And those are the kind of things where you can get tumors. So if you get something like an insulinoma, tumors that are producing pancreatic enzymes like insulin, those are the things that are associated with MEN. So if you have a history of an insulinoma yourself, or you have family histories of pituitary adenomas, and now you've got high calcium, or if multiple people in your family have had high calcium, particularly if they had it at a young age. So if you tell me that your mother had parathyroid surgery when she was 80, and now you're 60 and you've got primary hyperparathyroidism, most likely this is not genetic. You both just happen to get it. This is a disease that women get, men get it as well, but it's more common in women, especially as you get older, postmenopausal period. So, okay, if you both got it at a later age, I'm less concerned for a familial condition, for a genetic condition. But if you tell me that your mom got it at age 30 and now you're 40 and you've also got it, you're both getting diagnosed at a younger age, that's more likely. If you're a teenager or somebody in your 20s or 30s getting parathyroid disease, then a familial condition is a little more likely. having said that, even for young people, I often don't get genetic testing. So if there's no family history of high calcium or parathyroid disease, no other family history of weird endocrine tumors, you haven't yourself had a weird endocrine tumor, but you're 30 years old and you have primary hyperparathyroidism, I'm not going to immediately order genetic testing because it's not going to be all that helpful. It's not going to change what I do. I'm going to operate, basically. I mean, that's how you treat primary hyperparathyroidism. But there is a scenario in which I'll recommend genetic testing after surgery, and that is if I go in there and I operate on a 25-year-old and I find hyperplasia, meaning I look at all four glands are involved, that patient needs to get genetic testing because having hyperplasia at a young age is pretty unusual outside of these genetic syndromes. Now, having an adenoma is the most common scenario, especially if you're a young person. So most of the teenagers I've operated on, they had single parathyroid tumors. That's less likely a genetic condition. That's getting unlucky. It could still be genetic, but in fewer cases it's going to be genetic. But if they have hyperplasia, all four glands involved at a young age, that's when I'm ordering the panel to look at all the genes for this. Okay, so that's basically it. Not everybody needs it. Some people do, especially with a family history. If you're younger, if you've got hyperplasia, those are the people who are going to need genetic testing. And again, a lot of the reason is so that we know what to track and what other things we may need to test for down the road. So just to recap again, FHH, familial hypocalciuric hypercalcemia, genetic condition. It is caused primarily by these three genes. A lot of doctors know about the CASR gene. That's the calcium sensing receptor gene. That was the first one we knew about, and that is the one that is still most commonly tested for. Unfortunately, sometimes it's the only one tested for. So if I see a patient and they have kind of like a picture that makes me think FHH, I'm going to make sure I order all three of these, not just the CASR, because more and more cases we're seeing have positive GNA11 or the AP2S1 gene, not just CASR. But in older studies, CASR was the only one we knew about. And a lot of doctors only remember the CASR genes. I do have patients sometimes who come to me with kind of clear FHH. They've only been tested for CASR. It's sometimes necessary to retest for these genes. I will also say I don't think we're done finding these genes. These are the three we know about now. There are some that are kind of possibilities that I also include on the panels that I order that aren't exactly clear what they cause, if they cause it or not. But I know for a fact that there are more because I do have patients where I am fairly convinced that their underlying diagnosis is FHH, and yet all of these genes are negative. So in some patients, if I think they may have FHH, again, they've had calcium levels that are high for 20 years. Maybe somebody in their family also has high calcium, but all these genes are negative. We can still operate because there's still a chance that they have primary hyperparathyroidism, and I don't want to miss that. I don't want to miss a case of primary hyperparathyroidism because you're going to feel bad. You're going to get complications of it. So if I think there's a chance you have primary hyperparathyroidism, I'm going to operate. There are cases where I've operated and when I suspected FHH, but all the genes were negative. In a lot of those cases, I found a parathyroid tumor, but in a lot of the cases I didn't. And again, the operation is necessary because you need to see the glands. You need to make sure it's not primary hyperparathyroidism. But there are cases where, again, I operate, I see all four glands. I'm not convinced that there's primary hyperparathyroidism there, but I also can't show what gene is involved and prove FHH with genetics. So, like I said, all that is to say, I'm pretty sure there are other genes we're going to find later. Even a few years ago, all we were really looking for was CASR, and now we know to look for these other ones. So that's FHH. Now, when I get the panel, actually, a lot of times we include all of these genes as well, which are the familial hyperparathyroidism genes. So these are the ones most commonly associated with familial hyperparathyroidism. The first one, the CDC73, is associated more with kind of an isolated familial primary hyperparathyroidism, meaning, you see primary hyperparathyroidism and maybe nothing else. That's the only thing that kind of runs in the family. But you can also get jaw tumors with this. And CDC73 also is associated more with parathyroid cancer. Still, most of these patients are not going to have parathyroid cancer, but it's always got to be kind of in the back of your mind that this is a gene that can cause parathyroid cancer, and that you want to know about, want to let your family know about. GCM2 as well is associated with an isolated primary hyperparathyroidism, but these other genes are the ones associated with multiple endocrine neoplasia, or MEN. So MEN1 is associated with MEN1. RET is associated with MEN2A, and then the CDKN1B is associated with MEN type 4. So not all of the MEN syndromes are actually associated with primary hyperparathyroidism. A few of them are here, but there are MEN syndromes that do not include a predisposition for primary hyperparathyroidism. The most common one here, and the ones that's really often associated with primary hyperparathyroidism, is MEN1. Again, if you suspect a familial primary hyperparathyroidism, really makes sense to test all of these genes, not just one, because a lot of these syndromes overlap. With MEN1, a lot of times primary hyperparathyroidism is the first endocrine neoplasia to get diagnosed, and may even be the only one for many years. So it's not helpful, I think, to just test one. The CDKN1B, that presentation can overlap with MEN1. So it's just better to test all of these as a panel if you're going to test them. Sometimes you have to fight with insurance companies, but you should, and you should test all of these. Now, I will say on the panel I get it through Invitae, and I've added a couple of others that are sort of not as strongly associated with it, but we know that they have some relation to high calcium, so I add them on there as well. But these are the primary genes that we're looking for. But again, I just encourage people not to just get one gene tested, to get the panel tested if you are suspecting any of these. All right, so we can just go back to me. So, all right, now. Actually, that was pretty good timing, but okay, I want to recap. So for familial disease, really, it's more based on the history. That's the primary thing I'm looking for. Is I'm trying to figure out, what your history is. I always ask about family history of high calcium and parathyroid disease. That's on my intake form. I always ask about your surgical history, because if you've got pituitary tumor, which is not uncommon, then I want to be thinking about MEN. And I do want to try to diagnose FHH ahead of time if that is the case, or if there's a suspicion there. With familial conditions, more often they are going to present at a younger age. So the average patient with primary hyperparathyroidism is a 60-year-old, so an older adult. Now you have teenagers, you have people in their 20s, you've got really young people getting primary hyperparathyroidism, but if you have a familial condition, it is more likely to show up or start showing up at a younger age. So that's one more clue there, is if you have a young age, if you get hyperplasia, because that's much more common than adenomas when you have a familial condition. One final word on FHH, which is with FHH, right? You do get kind of a chronic stimulation of the parathyroid glands. So when you operate, sometimes you do see hyperplasia of the parathyroid glands, and people with FHH can develop what looks like primary hyperparathyroidism, or develop primary hyperparathyroidism essentially. So I have seen this. It's not impossible for somebody with FHH to have high calcium levels their whole life, meaning calcium levels that are in the low 10s, like 10.3, 10.4, somewhere around there. But then at some point, they start developing calcium levels in the 11s and 12s, and the PTH goes much higher, above 100. that person does need parathyroid surgery, even though they have FHH. So FHH is never a reason to deny somebody surgery. I mean, it's a reason to more carefully consider it, but you don't automatically deny someone surgery if they have FHH. You really want to see what the history is. You want to see their calcium levels over time. Now, if their calcium levels 20 years ago were all in the low to mid 10s, now their calcium's 12, right? They could have developed a parathyroid tumor on top of that. They could have parathyroid hyperplasia, but either way, it's worth doing an operation to go in there and look at all 4 parathyroid glands, figure it out, and try to get them cured. Now, what does cured mean? Cured for FHH means back to your baseline calcium. So it's probably not going to be in the 9s if your calcium level has never been in the 9s. If your calcium was 10.1 to 10.5 for all of your adult years, then that's what it's going to go back to once you're cured. It's not going to go into the 9s like for most people. It's going to go back to your baseline. So, all right. If people really want to hear more about FHH, we can talk more about that. You can ask a question. But FHH is a tricky one because, it's a bit misunderstood. Doctors aren't always sure exactly when to diagnose it. Low urine calcium is not definitive for it. You do need genetic testing. And then even the genetic testing is not definitive because there likely are other genes involved that we don't know about. Okay. Since it's almost 6:30, it's time to switch to Q&A. All right, so we don't have as many people, which is good, so we can spend time on the Q&A. All right, Carolyn asks, if I had hyperparathyroidism and removal of one parathyroid tumor, should I have regular checks as well as my daughter? Well, so it depends. If you don't have any family history of high calcium, and nobody else in your family has this, it's likely a sporadic case, but you personally should be checking your calcium at least annually. Annually is what most people do as they get older. When you see your doctor, you get a kind of regular lab panel, and calcium is typically included on that. So I do recommend for you checking it because there is always a chance that you could develop this again. Most people are cured with one operation, but not everyone is. If it does come back though, you'll see it in your labs again. I would let your daughter know that you have this history, just so that she can also check her calcium level out. Now, if she is much younger, so if your daughter is 20 years old, suppose your daughter's 20 and you're 50, and your calcium, you were diagnosed with a calcium of 10.2, and that's how they found your parathyroid tumor. Your daughter could have a calcium of 10.2, and that's totally normal for her age. So whenever I tell people, tell your kids, to look at this, they have to base it on age. So if her calcium is 10.2, but she's 20 years old, that's totally normal. But she should check her calcium. I mean, I recommend everybody just check their labs, get copies of your labs. Whatever labs you have done, get copies of them, and keep them in your records so that you have them. And she should regularly look at her calcium level as well as other labs. But she needs to know that this is slightly higher risk since you had this done. Okay. Rachel says, I likely had primary hyperparathyroidism since I was a teenager. One gland removed, other glands normal, PTH dropped to 14. No family history. Does my daughter need to be monitored for it? Kind of the same thing. I would say, your daughter needs to know about it, and everybody should kind of check their calcium level. As a parathyroid surgeon, I guess I'm biased here. I mean, everybody should know their calcium, right? But does she particularly need to worry about it? No, but she should know her calcium level. Had multiple fibroadenomas since age 17. Not really. Those are not, that wouldn't be one of the kind of classic associations with these genetic syndromes. Now, having said that, there are a lot of kind of benign tumors that can be associated with these, but just having benign fibroadenomas is not going to make me think that this is likely genetic, especially if you had just one parathyroid adenoma. The other tumors that I mentioned are much more commonly related. So things like if you had a pancreatic endocrine tumor or a pituitary adenoma, or medullary thyroid cancer is associated with one of the other MEN syndromes. So if you have one of those, which are classically associated with it, then it's more likely. And again, you would have, if you had MEN, you'd see hyperplasia. So if it was a single adenoma and you're cured, less likely genetic. Okay. Okay, Suzanne says, hi, Dr. Boone. You performed surgery in August 2023 and removed 2 parathyroid adenomas, diagnosed with primary normal calcemic hyperparathyroidism. Okay. Your calcium is still normal, but the most recent PTH is 66, which has you concerned about recurrence. Okay. So the first thing I want to know is what is the actual calcium level? Because a lot of times it'll be listed as normal, but it's kind of on the lower end. And that's usually where we see this PTH kind of creeping up. So the PTH of 66 with a normal calcium is not in itself that concerning. It's on the higher end, which makes me think that it may be, or it's more likely, a secondary presentation. So what I would like to see is know what the calcium level is. If your calcium level is on the lower end, meaning low 9s or lower, then it's secondary hyperparathyroidism, and what you want to do is treat that, which means looking at the underlying causes. It may just be that you need more calcium in your diet, may be that you need to take more calcium supplements. It may be that we need to check your 24-hour urine calcium to make sure you're not losing calcium into the urine, because that can be a cause of secondary hyperparathyroidism after surgery. So those are the things I want to look at. This is not at the point where I would say that you're going to need a reoperation. This really looks like secondary, which is fairly common after parathyroid surgery. And I discussed it on a couple months back with secondary. So normal calcium with a PTH of 66 sounds like secondary hyperparathyroidism. Oh yeah, let me see. Okay, yeah. So you said your calcium is 9.0. So this is definitely it. This is classic secondary hyperparathyroidism. Calcium of 9.0 is too low. Most adults want to be in the mid to high 9s, so we want to get your calcium level into that 9.5 to 10.0 range. And once we get it back there, then you should see the PTH level go back down. And yeah, you can always do the 24-hour urine calcium to see, are you losing calcium into the urine? If you're not taking calcium supplements, then you would need to start taking calcium supplements. But rule out something, calcium going into the urine. Okay, let me scroll back up. Hold on. Justin says hi and has CASR. Yeah. Well, the other letters were tested for, I'm sure. All right. So, and Justin, yeah. So there's always somebody weird with genetic stuff. So you had levels in the 10s, had surgery, they went down, and now they're back up, and now you got the mutation. It's really tricky. So it is very tough with FHH and these CASR mutations, and it's always a tough conversation because the kind of conventional wisdom that most doctors will say is people with FHH should never get surgery. So you will hear some endocrinologists, you may see an endocrinologist who will say that you have FHH, you never get surgery. That's not exactly true. There are people with FHH who develop enlargement of one or more parathyroids that is a problem and that will get better with surgery. However, like I said, you're not going to go back to normal, and the parathyroid glands themselves are not exactly going to go back to normal. When you have FHH, you can get overgrowth of all 4 glands because they are your calcium sensing receptor is not normal. So your parathyroid glands are never going to exactly be normal. And that's tricky. It's a very tough decision to say, when someone needs surgery, when they don't need surgery, and whether or not they're going to benefit from surgery. So yes, you are the odd one out there, and kind of illustrate the difficulty in dealing with FHH. Okay. Okay, so are adrenal gland tumors associated with primary hyperparathyroidism? They are associated with some of the MEN syndromes. So yes, the adrenal gland is an endocrine organ. Pheochromocytomas in particular are associated with primary hyperparathyroidism in MEN2A. So yes, if you've had an adrenal tumor, then MEN is definitely on the table, and you should get, if you now have parathyroid disease, you had pheochromocytoma, you definitely need genetic testing. Okay. So next question. What improvements post-surgery is more obvious for normal calcemic patients versus hypercalcemic patients? Oof. So that's a tough one. It's tricky because a lot of times when I talk about symptoms of primary hyperparathyroidism, what I'll say is, it makes sense that these symptoms are caused by high calcium levels because calcium is so important for the brain function, for muscle function, for, these things throughout the body, even, with the heart rhythm, all of that is related to high calcium. Calcium is what causes the arteries to be stiff. Calcium going through the kidneys is what causes the kidney stones. So it's all very obvious, when I say, okay, well, the calcium is related to nerve signaling, and so that's why it causes fatigue. It makes intuitive sense. But people with normal calcemic disease, meaning their calcium levels are totally normal, also get similar symptoms. So what am I talking about then? Well, it's clear that the PTH itself also causes a lot of symptoms. So an elevated parathyroid hormone, even without high calcium, can produce a lot of these symptoms. I don't have as good of an explanation for it. So I can't say, oh yeah, like the calcium is involved in the signaling and that's why the signaling is up. That makes sense. It's very straightforward. Reality is not as straightforward. The symptoms do seem to come on with elevated PTH in addition to high calcium. So what changes can somebody with normal calcemic expect? The same ones, the same changes, especially if they have the same symptoms. So for people with normal calcemic, I do hope to see some of the same symptom improvements. The things that might be more obvious for normal calcemic patients, with some normal calcemic patients, it's actually long-standing secondary hyperparathyroidism. So the things we might be seeing more with them, we might be diagnosed it because they have osteoporosis, so they have bone pain. But people with primary hyperparathyroidism get that too. The range of symptoms for people with sporadic, regular old hypercalcemic primary hyperparathyroidism is huge. Some people feel terrible. They're tired. They can't think straight. Others feel pretty okay. They have a little bit of bone pain in their feet, but otherwise they're doing okay. Normal calcemic patients are the same. There's a broad range of symptoms. And so in general, would I say that their symptoms are a lot different than the hypercalcemic? No, not really. And, the improvements, I'm hoping for the same improvements in normal calcemic patients as I am with hypercalcemic. So that was kind of roundabout. Hopefully that answered that. Basically, I don't know. I hope for the same improvements in everybody. Linda says, serum calcium ranges from 9.4 to 10.4. 24-hour urine calcium is less than 5. And Vitae genetic panel is negative. Thoughts? Yeah, so 24-hour urine is not perfect. Even with cases of FHH, seeing a 5 is pretty low. So I would make sure that's repeated just because, mistakes can be made. These tests can be off sometimes. So if, something was wrong with the jug, the stuff they put in the jug, I don't know. I would just make sure it's correct and repeat that 24-hour urine calcium. If your urine calcium truly is 0, and you know, or 5, and you've had these, but you have a picture that kind of looks like primary hyperparathyroidism, you have to go with the other clues. So I would look at how long your calcium's been high. If your calcium was in the 9s consistently for years until 3 years ago, and now it's in the 10s, that represents a change that is more concerning for primary hyperparathyroidism. Or if you look back and actually your calcium was in the low 10s consistently, or 9.4 to 10.4, but that's been for the last 30 years, that's less likely primary hyperparathyroidism and more likely FHH, even with the negative panel. And that panel, I'm sure, included, you know, the genes I mentioned. If there's a concern for primary hyperparathyroidism, sometimes you can still operate, but it's not clear. It really, you'd have to base it on, you know, your history, any family history. So has anybody in your family also had high calcium or also had these calcium levels that were consistently in the 10s? You want to look at all of that and see if things are, you know, could possibly be, you know, something else. So could be, you know, primary hyperparathyroidism. But yeah, that's kind of what I would do. Now, some people, you know, after all of that, if it's still not clear, and it looks like the, you know, calcium level is rising, or the PTH level is rising over time. So the calcium level was in the 9s, now it's in the 10s, or the PTH level was low. So a lot of times with FHH, you'll see these PTH levels that are kind of normal range. Sometimes they kind of go to the high range, but they usually don't get too high. So if you have a PTH level that, you know, was in the 40s and 50s, but now it's in the hundreds, those would all be signs that maybe you think need to pursue surgery as a diagnostic operation. And diagnostic operations are done, meaning you go in there and you're not 100% sure whether it's primary hyperparathyroidism or not. I do this operation when it's just not clear, and sometimes it really isn't clear. Especially you've done all that you can. You've done the genetic testing. You know, you've asked about the family history. You've asked about personal history. You've gone through all the hoops. You've tried to figure out. You know, you tried to diagnose it, FHH, if it is there, and if you can't, then sometimes you need to go through surgery. And during the operation, you want to see all 4 parathyroid glands. If you can, you want to look at all of them and make sure that you're not missing a parathyroid tumor. Okay. I hope that answered it, Linda. But you know, feel free to ask more. Okay. Okay. James says, I am 10 months post-op with 3 hypercellular glands removed. So again, sounds like hyperplasia. If 3 were involved, then the last one probably wasn't completely normal. But so you had 3 removed, which is appropriate. My labs are stable with supplementation. As a result, post-surgery, I've suffered with what seems to be a metabolic neuromuscular dysfunction and have become disabled due to limited muscle function in my legs. Have you seen this with other patients? If everything is normal now, so if your calcium level is totally normal in the 9s, it would be unusual to see a severe metabolic dysfunction causing significant weakness or disability in the legs. I would be more concerned that this is actually something else. So if you haven't seen a neurologist about this, then that would be my next step, because this is not typical. Now, muscle weakness and muscle issues can occur with any derangement in calcium. So you can see it with a high calcium, you can see it with a very low calcium. If your calcium level, if you said your calcium level was 8, then that could definitely be an issue. But if your calcium level, again, is totally normal and you're not on massive doses of calcium, then I think that the best thing to do is to see a neurologist, because it may be something unrelated. It may have been, the shift in calcium after surgery may have temporarily kind of worsened the symptoms, and that's why it seems like it's all related, but I would be concerned that there's something else going on. Okay. And Kira says, I've always wondered about the effect of high PTH versus the effect of calcium. Yeah, and this is not something we've totally figured out either. So, yeah, high PTH does damage too, in addition to just high calcium. Okay. Liz says, after a successful parathyroid surgery in March, my calcium is finally 9 as of this month. I'm taking 5 berry melts a day for the next 3 months. I'll then have my calcium checked again. How often should I have my PTH checked? Well, it depends. So if your PTH, it doesn't need to be checked as often as the calcium. I mean, that's what I will say. You just want to see that it's kind of responding appropriately. So if your calcium is low, you want to see the PTH kind of go up. And then as the calcium level goes up, you should see the PTH level drop. But it's more important to get the calcium in line rather than continually checking the PTH, right? Because I know if we can't get that in normal range, then PTH may not be in normal range either. So, if you're getting your calcium checked once a month, I definitely wouldn't check the PTH that often. But in the next 3 months, I think checking the PTH level there is good. Once things kind of settle down and everything is under control, usually I just recommend checking the calcium. Like when you get back to just checking annual labs, you get to a stable dose of calcium, and you're doing well, and things aren't fluctuating as much, then just checking calcium annually is fine. If there's any problem with the calcium, then rechecking the calcium and PTH is necessary. But for most people, I don't think you need to check the PTH as often or even every year once things have settled. Okay, Mike says, my endocrinologist was concerned at my last appointment that I'm still taking 6 Citracal Max tabs per day. My PTH has been low normal, 22, and my calcium was 9.6. He told me to reduce to 4 per day, and I think he wants to see if my other parathyroids respond appropriately. Is that reasonable? Yeah, it's not unreasonable. If you're feeling well otherwise and you're not getting symptoms of low calcium, then it's totally reasonable to drop it down. Now, I will say, there are people who just need to take a little more calcium, and that's okay, and it can be lifelong. As long as you're following certain things, making sure you're not getting way too much calcium. 6 Citracal a day is not a crazy dose. But if you're feeling well, is it reasonable to drop down and see what happens? Sure. I mean, why not? I think, I wouldn't wait too long. I would drop down to 4, see how you feel, and recheck in a month. If you're not feeling well, if you start noticing symptoms, take more. Long term, it's not a bad idea to check a 24-hour urine calcium if if you were taking a massive dose. So if you were, needing lots and lots of calcium, it's reasonable to make sure that calcium is not going into the urine, and increasing the risk of kidney stones. But yeah, is it reasonable? Sure. I mean, I'll go by how you feel. So is a genetic connection more likely with hypercalcemic PTH patients or with normal calcemic PTH? More likely hypercalcemic. So usually with these genetic syndromes, you get fairly classic primary hyperparathyroidism. You'll see high calcium levels, high PTH levels. You get classic presentation typically. Ludmila asks, since kidney stones run strongly in my family and mine started at a young age, I'm wondering whether a genetic stone disorder or hypercalciuria could explain this rather than parathyroid disease. How confident are we that my bones and stones are coming from the parathyroids? Calcium is 9.9, PTH is 42. Can surgery for hyperplasia help? Surgeon suggested it. Well, so first I'd want to know if you actually have primary hyperparathyroidism. Because you can, sometimes kidney stones run in families. So you may just have a predisposition to getting stones because of that. You may have hypercalciuria. that's unrelated to your family history as well. But I don't know that you have primary hyperparathyroidism, especially not with a normal calcium and PTH level. Now, I'd want to see your history. If a surgeon suggested surgery, maybe you have high calcium levels. So if you've had calcium levels above 10.0 and you've had, higher PTH levels or non-suppressed PTH levels with those calcium levels, then I would diagnose primary hyperparathyroidism. But if your calcium levels have all been normal, then no, that doesn't seem to be the cause of your kidney stones. You can just have high urine calcium and not have primary hyperparathyroidism. So I would just want to make sure that diagnosis is correct. Now, you mentioned, how confident are you that the stones are coming from that? Well, not entirely. So I do have patients who have a very long history of kidney stones. They've had stones for the last 30 years, and now they have primary hyperparathyroidism. For almost all those patients, I don't think they had primary hyperparathyroidism for 30 years. I don't think their stones are due entirely to parathyroid disease. Could parathyroid disease make it worse? Yes. So what I'll often see is somebody will have a stone 30 years ago, and then 10 years later have another stone, and then 5 years later have another stone. But then in the last 3 years, they've had 6 stones. Clearly something different has happened in the last 3 years. That's from the primary hyperparathyroidism. But the stone from 30 years ago is not related to parathyroid disease. So there may be multiple causes. If you do have primary hyperparathyroidism, though, it makes sense to get it treated. It may not completely eliminate your stone risk, but it's not going to help if you've got a high calcium level in your blood being filtered by the kidneys. So, but first you want to settle the diagnosis, because if you don't have primary hyperparathyroidism and you just get a few parathyroids removed, no, it is not going to help. It's not going to help your kidney disease at all. Okay. Another question. Would you recommend all patients who have 3 or 3.5 parathyroid glands removed, or only those with hypercalcemic hyperparathyroidism, or patients with normal calcium? Okay, so who should get genetic testing, basically? So not everybody with 3.5 glands removed needs to be tested. Parathyroid hyperplasia occurs in about 10% of patients. The number who actually have genetic syndrome is much lower. So it's really only if it's hyperplasia in a young person with classic disease, that's typically who I'm recommending genetic testing on. If it's somebody with, less of a convincing picture, who is older and has hyperplasia, it's not as likely. But again, hyperplasia is slightly more common in normal calcemic cases. So if you have normal calcemic primary hyperparathyroidism, you're slightly more likely to have multiple glands involved, including hyperplasia. Most of those patients are not going to have a familial syndrome. So in most of those, I don't recommend genetic testing unless there's something else. Again, you have to look at the whole picture. I want to see, are there any other signs of familial disease? But yeah, if it's just hyperplasia, I don't get genetic testing in those cases. Rebecca says, how important is a 24-hour urine calcium test? Well, it's important in certain scenarios. If I suspect FHH, then it's absolutely essential. So if you've had high calcium levels for 30 years, I am 100% going to check a 24-hour urine calcium if you haven't had it done already. In other cases where you have classic primary hyperparathyroidism and there's really very little question there, then a 24-hour urine calcium is not going to help very much. So I typically won't get it, again, unless the picture is a little bit unusual or there's something else odd about it, like the calcium level for 30 years. Or family history. You've had multiple family members who've had parathyroid surgery. It's a little unusual. I would get a urine calcium to make sure that doesn't look like FHH. But is it necessary in most cases? No. You had normal calcium levels for 10 years ago, and slowly over time your calcium level's gone higher, and now it's high, and that's classic disease. So, okay. So James saw a neurologist and everything's okay. Honestly, I'm not sure. This is one of those cases where bodies are kind of weird. This is you've got this neurologic issue. Could it be related to calcium? Absolutely. But it's good to rule out any neurologic stuff. And unfortunately, I don't have an answer for you. Suzanne says, how much calcium should I be taking? Does it matter if it's supplements or calcium from food? Okay, wait. So let me scroll up. So your calcium was 9.0. Yeah. So in general, if your calcium level's on the low end and the PTH is kind of creeping up there, then I typically start people on 1,000 milligrams a day of calcium. It depends on the situation. So it depends on, do you have osteoporosis? Do we suspect that there's calcium going to the urine? So have you had a kidney stone before? But a lot of times that's the dose that kind of start at is 1,000. Now, if you're already taking 1,000 and that's your calcium, then we need to go up, obviously. But if you're not taking any calcium, and I see a calcium level of 9.0, a lot of times 1,000 milligrams a day is where I will start. And I do it in divided doses usually, so about 500 or 600 milligrams at a time. You also want to take vitamin D, but your vitamin D level of 146, if that is the 25-hydroxy in nanograms per mil, then it is in the toxic range. Now, vitamin D is weird because, toxicity really results in high calcium levels. So if your vitamin D is toxic, the thing we're worried about is calcium that's too high. Now, if your vitamin D is toxic, but your calcium is not high, then it's not the problem. But I would want to find out how much vitamin D you're taking and why it's that high, because we really don't need it to be that high. I usually recommend around 2,000 units a day for most people. So if you're taking more than that, then you probably need to back off. And yeah, I do recommend supplements. I like getting things from diet for the most part. So I'm a big fan of lifestyle medicine and getting the nutrients that you need, or the vitamins you need, and minerals you need from your food. But if you've been eating your regular diet and your calcium is 9.0, I don't necessarily want you to go out and start shoveling, cheese or milk into you. There are likely risks to eating a lot of dairy. So I don't want to start doing that. Are there things you can do to help your diet in terms of calcium? Definitely. Kale has a lot of calcium too. You can eat yogurt. That's healthy. Milk is not going to be terrible for you. But in general, if your calcium is 9.0, I want to at least start getting it up with supplements. Again, I usually start at 1,000, and then if somebody really wants to come off of it, so I want to see the response first, so I'll put you on 1,000. We'll recheck labs in a month. Calcium's 9.5 now, and the PTH is 40. Great, so we know you responded. At that point, if you wanted to try to drop down on the calcium, that would be reasonable. But a lot of people, really significantly changing their diet may not work, and it may just be better to stay on the calcium supplementation. I will say, if you're really trying to get enough calcium, don't eat spinach. It's one of my biggest things I tell people, just don't eat spinach because the oxalate levels are so high, they're going to prevent you from absorbing the calcium. So if you're having that spinach salad every day, just cut that out entirely. And that will help you get the calcium you need. But really, if your calcium's already low, I want to start with supplements. I want to make sure we can get it up. Get that calcium level up. And then at that point, if you wanted to back off a little bit and replace some of that calcium with some of that calcium with dietary calcium, that would be fine. But if it doesn't work, then you go back on the calcium supplements. Okay. Rotod asks, is it possible that a medication for MS like Kesimpta could cause 3-GAN hyperplasia? Calcium rose in the last 2 years before surgery and have been taking it. I'm going to have to look that up. I actually don't know. There are medications that can cause high calcium and cause, parathyroid disease. I don't know about that, so I'll need to investigate that. Thank you for pointing that out. We'll see. Okay, could you post on your website all the different genetic tests one should ask for if one had surgery for hyperplasia? I could, yeah. I don't know if I mentioned on the website the genetics of it. It's not a bad idea, but again, when asking for these, I mean, your doctor will need to kind of decide whether your situation completely warrants it. But again, if you're getting genetic testing, then the doctor really should order that panel and not just a single gene. So yeah, I will try to figure out if we put that on the website. All right, Marianne asks a question from Canada. How long does it take to reduce vitamin D toxicity? Tricky. So usually a while, longer than you think. Vitamin D is a fat-soluble vitamin. So if I see a vitamin D level in the toxic range, usually I'll have the person stop immediately, stop taking vitamin D, and then I recheck labs in 3 months. And some of the time, that's enough to see it go back down into the normal range, depending on how high it was. But other times, it requires several more months after that. So the calcium, depending on where it starts, again, if you're really high, really way out of range on your vitamin D, it could take 6 months for it to come down because it is a fat-soluble vitamin. It's stored throughout your body. It takes a while to even out. But sometimes you see it come down fairly quickly, especially if your vitamin D level is not too high, it's not too toxic, then it may only take a month to see it. And then you'll see the calcium start improving too. So if you're seeing high calcium levels due to vitamin D toxicity, it may take a few months for that calcium level to also drop down to normal. Okay, I think that's it. I think I got everything. And it's 7:02, so time to head out. But thank you everybody for tuning in. Yeah, come back next month. All right, take care. Have a good night.